We can start, Dr. Vinita. Hello.
You are muted. You are muted. Please unmute your mic and start. Thanks.
Yes. Thank you, Dr. Srinivas, and a very good morning to all who have joined this meeting. I am extremely privileged to get this invite to speak to Hyderabad Intensive Care Symposium, and I apologize for the initial technical glitch that we faced. So today we will be talking about the newer hemodynamic concepts. As the topic itself says, they are new, and most of us will not be having the practical bedside experience. So we will only be discussing the concepts today. I will try to explain it the best way I can. And if at the end of the talk, we can discuss the queries and any inputs from your side. So today we will be taking up 4 topics. So we will start with ventricular-arterial coupling. Next slide, please. So coupling is basically working in tandem. So coupling, when we talk in the scenario of ventricular-arterial coupling, it is the pumping action of the heart when it is connected to the load opposed by the arterial system. So in this topic, we are discussing the coupling between the ventricle and the arterial system. When we come to the mean systemic filling pressure, we will be talking about the coupling between the ventricle and the venous system. So as we know, arterial system is a high pressure system. So this VA coupling basically describes the interaction of the left ventricle and the high pressure arterial system in terms of a volume and pressure relationship. Normally, do we see coupling? Yes, coupling takes place in every beat of the heart. And a very good example, if I can quote here, is a physiological aging that takes place and the arterial stiffening that accompanies the physiological aging. So the ventricle tries to remodel itself to take care of the VA coupling. So the concept is the heart and the aorta are interdependent and they are complementary to each other. So the ventricular system function and the systemic arterial properties must be expressed in the same unit. Otherwise, we cannot study them. So the unit that we use to study them is a dimension of the elastance. So elastance, as we all know, is a change in pressure for a unit change in volume. So for that, we need the pressure volume loop to study the VA coupling. Next slide, please. So this slide is a little crowded, but it is the most important slide, so I will spend some time here. So as depicted in the picture, this is the PV loop of a cardiac cycle. The loops have been superimposed for many cardiac cycles to get the slope and the line. So the red point show the maximum elastance for each cardiac cycle. And as you can see, there is a straight line connecting them, which is the end systolic pressure volume relation line, or the ES-PVR line. Now the slope of that line is the elastance of the left ventricle. So basically it shows the left ventricular contractility. So we will call it ES. In some literature, the terminology EV can also come. So these are interchangeably used terminologies. The diastolic property of the ventricle is given by the end diastolic pressure volume relationship. And this is the line which we get at the end of the loop. This is the ED-PVR. Now the width of this curve is the volume, which is the stroke volume. And the line that is connecting the ES-PVR with the ED-PVR is the effective arterial elastance as measured by its slope. So we will call it EA. So when the point where the EA crosses the line of EES, that point is the ventricular arterial coupling point. So that is the point of VA. So further, if we see the area that is enclosed in the rectangular curve, that shows the stroke work or the work done by the heart in one beating. And then you can also see a triangle, a blue triangle formed by the ES-PVR and the ED-PVR. Now this represents the potential energy of the ventricle. So if we have to consider the total work done by the heart, that will be the sum total of the potential energy and the stroke work. So ventricular efficiency will be the ratio of the stroke work and the PVA or the potential energy. Next one, please. So basically, VA coupling is the ratio of the elastance. So it will be the ratio of the EA by EES. It has the greatest efficiency when the elastances are matched. That means the ventricular elastance and the arterial elastances match, where the optimal transfer of the blood from the LV to aorta takes place. So the blood pressure, the LV pressure, and the cardiac output are maintained in the physiological range by the VA coupling. Next one, please. So there is a formula. It is actually looks a little complicated, but it is very simple. The VAC, that is the VA point, is the ratio between the EA and EAS. So EA basically what is it? It is a change in pressure by the change in volume. So it is the end systolic pressure divided by the stroke volume. And similarly, the elastance of the ventricle also is the end systolic pressure divided by the end systolic volume of the ventricle. So if we do a simple math, then we come down to the last line, which shows that VAS is equal to end systolic volume divided by the stroke volume. So this ratio is important when we are doing the echocardiographic assessment of the VA coupling. So VA coupling is associated with optimal ventricular efficiency at 0.5, where we say the arterial elastance is 1/2 of the ventricular elastance. But like I said previously, if they have to be matched, then the ventricular elastance has to go up. So then that is not an optimum condition of working. So in a stressful condition, the ventricle will sacrifice its efficiency to maximize the stroke work so that this ratio becomes 1. So if we, I will not go to the detail of this formula, but in a healthy individual, the left ventricular ejection fraction approximates 67%, which roughly corresponds to a VA coupling of 0.5. Next slide, please. So what is the elastance? So left ventricular elastance, interchangeably, we can also call it the EES. So it is basically the characteristic of the cardiac function. It depends on the contractility and morphology. It is independent of preload and afterload. And EV is the necessary intracavitary pressure required to increase the volume by 1 unit. And the normal value is 2.3 millimeter mercury per ml. Next slide, please. So I would request all to focus on the highlighted sentence here. Higher the elastance, greater is the sensitivity to volume change, and more variable is the pressure. So ideally, do we want a high elastance or a low elastance? So in the artery setup, if we are talking of high elastance, we are basically talking of a stiff artery. Similarly, in the ventricle context, if you are talking of a high elastance, that means we are talking of a overworked ventricle. Next slide, please. So these are the normal values which are available in every book. Next slide. So when does the uncoupling happen? Does uncoupling ever happen? Yes. Under stressful condition, under certain hemodynamic conditions, there is an uncoupling. And we say uncoupling happens when the EA value exceeds the EES value. So the ratio becomes more than 1. Up to 1, we can consider it optimum, although the ventricle has sacrificed its efficiency. So next slide. So a little bit of afterload. What is afterload? These are all the extra cardiac forces opposing the left ventricular ejection. It is defined as the slope, which I have already shown. This is a cumulative parameter of the entire arterial system and not just any point in the aorta or a particular segment. Next slide, please. So just to a point of repetition, LV efficiency is maximized during normal physiological situation with a ratio of 0.5. During stress, the stroke work is maximized, so the ratio becomes 1. If this ratio is altered, then it could be a mark of disease severity. It could also be an independent predictor of poor outcome in case of a cardiovascular disease. Next slide, please. So can we measure them on the bedside? Yes, they can be measured by invasive and non-invasive method. So for invasive method, we need the cardiac catheterization to give us the ventricular volumes and pressures. So we can calculate the EA and the EES or EV. In the non-invasive method, we can do a cardiac echo coupled with a blood pressure measurement. To take out the EA, we can use a simple formula, which is 0.9 times the systolic arterial pressure divided by the left ventricular and systolic volume. So this also can be obtained from the echo. So this is the echocardiographic picture. This I have taken from the internet. Now we need 2-3 parameters here. One is the LVOT VTI, which for an example, I have taken the value as 13.1. If the heart rate is 81 and the LVOT diameter is 2.18 centimeter, then calculating this, we can find out that the stroke volume is 49. So then what is the VAC? VAC is the effective stroke volume, systolic volume divided by the stroke volume. So it is 41 divided by 49, which is 0.85. Next slide, please. Now there is a concept called dynamic arterial elastance. So this is basically a ratio of the respiratory variation of the pulse pressure to the respiratory variation of the stroke volume. It can be measured by echocardiography or by invasive hemodynamic monitoring. It is an indicator of VA coupling and also shows us the cardiovascular efficiency. It has been used to predict successful weaning from noradrenaline infusion, and it can predict intraoperative hypotension with a good predictive value. Next slide. So where do we apply the concept of VA coupling? In anesthesia practice, we know that anesthetic drugs can alter the vascular properties. They could alter the EA. Some of them, most of them have got less effect on the EES because the drugs are more or less safe that are used now. Remifentanil has been used to reduce both EA and ES, but overall the change in the VA coupling does not happen. Next slide. In the ICU setup, there are a lot of scenarios where the VA coupling concept can be used. So this table has shown many of them where we have what is the change in the elastance of the ventricle, elastance of the arterial system, and also the VA coupling. So at leisure, one can go through it. We cannot describe each for the interest of time. So I will go to the next slide now. Supposing there is a heart rate change either during exercise. So what happens? There is an increase in the elastance of the ventricle and also the artery. So there is near optimal VA coupling. So there is a concept called Bowditch effect, which is the force-frequency relationship of the ventricle, which says that whenever there is a heart rate increases, the ventricle would try to increase its elastance so that the VA coupling is matched. This effect is changed in heart failure. So the force-frequency relationship does not come into effect in a pathological state. Therefore, we get VA uncoupling in such scenarios. Next slide, please. What happens in hypovolemia? There is severe tachycardia. If hypovolemia leads to a serious tachycardia, then there is an increase in the EA, and this will aggravate the VA coupling because in this pathological situation, the force frequency adjustment will not happen. In a vasoplegia, there is an alteration in the vascular homeostasis, which leads to severe arterial hypertension with a low systemic vascular resistance. There is an altered compliance. There is a change in the pulse wave velocity. However, the overall cardiac output may be preserved or sometimes it can be altered. So there is only EA change. The EES remains unchanged and the ratio could be high or it could be maintained depending on the situation. Next slide. Similarly, in septic shock, we see that 70% of the patients have got a VA uncoupling. There are hyperkinetic, hypokinetic, and the normokinetic phenotypes where the changes can happen. In the hyperkinetic, we have got decrease in the elastance of the artery. In the hypokinetic, it is mostly decrease in the elastance of the ventricle. And in the normokinetic, there is less change, so the ratio could be maintained. If this is associated with persistent tachycardia or the use of vasoactive drugs, then that could lead to a VA uncoupling. Next slide. In an acute LVF, there is a high ratio. Again, tachycardia is associated with increased EA, which causes a decreased diastolic time and a decrease in the vascular compliance. So the frequency potentiation of the contractile function of myocardium is decreased in the failing heart. So in cardiogenic shock, there is a severe decrease in the compliant elastance of the ventricle. And in a heart failure where there is preserved ejection fraction, there is increase in the arterial elastance, that means stiffness, and also EV, which causes cardiac hypertrophy and remodeling. So it could be in a normal situation, the patient could maintain the hemodynamics, but if there is stress on this patient, then uncoupling can take place. Next slide. So after the VA coupling, we will come to the, we will take the next two topics together because they are interrelated. So it is about the stressed, unstressed volume and the mean systemic filling pressure. So I have taken both of them together because it becomes easy to understand. Next slide, please. So before we go any further, let us take a minute here to understand the circulation of our body. So there's a very interesting model which has been proposed by Magder et al. So they call it the bathtub model of the cardiovascular system. So if we imagine a bathtub, then we have got a bathtub, which is the reservoir. Then there is an inlet, which is a tap that lets the water in. And there is an outlet, which lets the water out. So in our system, circulatory system, if we consider the entire arteriovenous circulation to be the bathtub, then the inlet would be the cardiac output and the outlet from that system would be the venous return. So normally in a bathtub, so there is some space left below the outlet. So in the biological scenario in our body, that amount of water or volume which is there after everything has drained out is the unstressed volume. Now to keep the circulation going or the bathtub filling, we need some input. Now that input has to come in the form of a cardiac output. So to get that cardiac output, we need more volume. Either we increase the cardiac output or we get volume from outside. Now once we get that volume, the bathtub is filling. It means in our system, the pressure is rising. So that volume which causes the pressure to start rising in the circulation, that is the stressed volume. And as to get the circulation going, we have to now start playing between the unstressed and the stressed volume. So this is a very simplistic model to understand the importance or the concept of the stressed volume and the unstressed volume. Next slide. Yeah. So we know that our venous system holds about 70% of the total blood volume, which is approximately 3.5 liters. And venous compliance is 40 times more than the arterial compliance. It means you can make them hold more water, more blood. So that is a huge reserve. So it also means that our unstressed blood volume is around 70% of the total blood volume. So when we do a venoconstriction, either by a sympathetic stimulation or by using certain drugs, then these unstressed volume are moving to the stressed volume. So they are getting into the circulation and they are adding up the volume of the stressed volume. Next one. So like I said, the draining from the system happens by venous return. So what exactly the venous return? The venous return is the upstream to the right heart. So it is the flow of blood from the systemic venous network right towards the heart, which is the right side of the heart. At a steady state, the total venous return is equal to the total cardiac output. So all the blood that comes to the heart is again ejected out. And this venous system is a capacitive system. It means it has high compliance and a high capacity to hold. Next slide. So what determines the venous return? We all know this. Mean systemic filling pressure, the right arterial pressure, and the resistance to the venous return. Next slide. So when we say mean systemic filling pressure, like I said, what exactly is this pressure? This is the pressure when nothing is happening, which means that if the circulation has stopped and the amount of pressure that we have, the amount of blood we have, and the pressure they exert on the wall when there is total circulatory arrest. So that is the mean systemic filling pressure. Next slide. So the pressure that will be measured at all points of the circulatory system if the heart were stopped suddenly and the blood is redistributed instantly in such a manner that all pressures are equal. So this is basically the pressure exerted by the wall of the circulation of the heart and the pulmonary vessels on its fluid content. So this shows the elastic recoil potential stored in those walls. Next slide. So then what is the mean systemic filling pressure? So today we are concerned about the systemic filling pressure. So this is the pressure only in the systemic circuit when there is total stoppage of circulation. So basically we are excluding the heart and the pulmonary vasculature and we are only taking the pressure in the systemic circulation. Next slide. So mean cardiac filling pressure is only the mean pressure in the motionless cardiac chambers. So this is not of importance to us today. Next slide, please. So if we see this curve shows that as we go on filling the blood from 0%, 50% up to 70%, there is no increase in the mean systemic filling pressure. Now at the point around 70%, the pressure gradually starts increasing. So that percentage of volume is our unstressed volume. So usually the value is 0 and it constitutes around 70 to 85% of the blood volume. Next slide. So stressed volume is volume of blood that must be removed from the vasculature to decrease the transmural vessels from existing value to 0. So that means this is the volume that causes a blood pressure to rise from 0 to whatever level it is. It normally constitutes 25 to 30% of the predicted blood volume. The systemic filling pressure is directly proportional to the stressed blood volume, that is a blood reservoir of the circulation, and the potential energy stored in the wall of the systemic and the entire vascular component. So this is the venous return graph where we see the blue line shows the venous return. As the venous return as the cardiac output increases, as the venous return increases, the right arterial pressure will go on increasing. Now the red curve is the Frank-Starling or the heart contractility curve. So what is venous return basically? It is the difference between the systemic filling pressure and the right arterial pressure divided by the resistance to the venous return. Next slide. Then what is the role of the heart then? The heart should keep a significant difference between the systemic filling pressure and the right arterial pressure, because if this gradient is not maintained, then the venous return is not happening. So here comes the role of the pump. More potent the pump, lower is the right atrial pressure and higher is the venous return. In the left ventricle, the left ventricle will pump blood into the high pressure circuit and distribute blood in the resistive system. I will take just half a minute to ponder over this line. More potent the pump, lower is the RAP. It means the RAP, surrogate of RAP is our CVP. So if we say that the end point of fluid is rise in CVP, then we are actually going against the concept of the mean systemic filling pressure, because if we are increasing CVP, then by this equation, we are decreasing the venous return. So this is a new concept which we have to take into account. So PMSF is the upstream pressure. It must be higher than the right atrial pressure or the CVP. So this is the driving pressure. The difference is the driving pressure, which is a venous return. And right heart must pump blood to the pulmonary circulation to keep the RAP low. So the venous return could go going. The normal values are given here. In Guyton, way back in 1950s, he came up in dead mongrel dogs that the value was 7 to 8 millimeter mercury. Later on, during AICT implantation where a VF is induced, it was found that it was 12 millimeter mercury. And subsequently in 2015, some recently just expired ICU patients who had already catheters in place, intraarterial and invasive monitoring lines. So it was found that it was around 12 millimeter. So the normal MSF would be anywhere between 0 and 12. So what determines it then? It is the tone of the smooth muscle of the systemic circulation and also the volume of fluid in the systemic circulation. And here it is the stressed as well as unstressed volume. To understand how exactly the concept works, let us see what happens in sepsis. In sepsis, what we get is a distributive shock which causes hypotension and vasodilatation and increased compliance. So what happens? The stressed volume has changed into unstressed. The PSMF decreases and the venous return decreases. So on the right side, we have got 3 tubs that shows the unstressed and the stressed volume. If you have to keep the circulation going, we have to increase the amount of the stressed volume. So how do we do that? Either we give fluid from outside, or we could convert the unstressed to stressed by causing a vasoconstriction in the way of vasoactive drugs, which is shown in the third box, where the right atrial pressure is going up significantly when we are causing the vasoconstriction. Next slide, please. So this we have already covered. So I would go to the next slide. So there are, what are the clinical applications of the concept of systemic filling pressure and stressed and unstressed volume? So let us see 3 clinical scenario. One is a hypovolemia. So what happens in hypovolemia? The mean systolic filling pressure is shifting, is decreasing. Okay, so that also is decreasing the right atrial pressure and the cardiac output. If we come to the graph B, which shows the cardiogenic shock. So what happens? The point of equilibrium here is shifting to right and down. The right atrial pressure is increasing and the cardiac output is increasing marginally. Now, what happens in septic shock? In septic shock, we could have a hyperkinetic shock or a hypokinetic shock. So depending on where this Frank-Starling curve is, we are getting either an increase or a decrease in the cardiac output. However, our systemic filling pressure is also changing here. Next slide. So what happens when we do a volume expansion? We are basically increasing the stressed volume and the systemic filling pressure. So when we do a volume expansion, the systemic filling pressure will increase. But we have again two sets of patients, like we all know. We have got responders and we have got non-responders. So in the responders, the cardiac output increases, as you see on the left side of the graph, whereas in the non-responders, even if the systemic mean pressure is increasing, still the cardiac output is increasing very, very minimally. So this is also an practical application of the concept of systemic mean filling pressure. Next slide. Now, what happens when we do a passive leg raising? So this is basically transferring the venous blood from the lower legs and splanchnic vessels to the heart. So the stressed volume is increasing and the PSMF also is increasing. There is no rise in the resistance to the venous return because it is a very physiological test. So we are not doing anything active here. However, in situation where there is an intra-abdominal hypertension, where already there is less blood in the splanchnic vessels, there will be less recruitment of the stressed blood. Next slide. So this concept also puts the use of noradrenaline into a newer perspective. How? Constriction of the venous along with the arterial system happens when we are giving a noradrenaline infusion. So there is recruitment of the unstressed blood volume, which is equivalent to a volume of 1 liter. So this increases the cardiac preload in the volume responsive patient. So the SMF will initially increase, but gradually it will decrease because noradrenaline does not remain in circulation for long, and you also have a capillary leak going. So this rise in the SMF actually is acting synergistically with the fluid infusion. So noradrenaline is restoring the pressure as well as it is potentiating the effect of fluid administration by getting the unstressed volume to the stressed volume. So increasing the effective circulation volume of the fluid or the blood. So in this case, should we start noradrenaline early or late in the process of resuscitation? Obviously, it has to be started early because it is optimizing the use of our own blood circulation, which is there. Next one. So how do we measure? So we measure it by indirect methods. So one is through the heart-lung interaction method, which is called the inspiratory hold maneuver. Then we have something called the arm stop flow measurement. Then there is a calculation of analog for the SMF, which we will come later on. It is done by a formula. Next slide. So in inspiratory hold method, this is applicable to mechanically ventilated patient and sedated patient with a central venous catheter. It should not be done when there is cardiac arrhythmia or there is rapid change in the hemodynamics. This technique is operator dependent, so sensitivity and specificity could differ. CVP may be altered due to incorrect catheter placement, so these are the caveats. And arterial pressure decreases during inspiratory hold, hence tachycardia may increase the SMF. So these are the caveats. Next slide. So in this method, what we do is, in the stop flow method, there is a rapid cuff inflation in the arm for around 1.3 seconds. And the pneumatic cuff inflation takes place and you inflate it up to 50 millimeter above the systolic pressure. The arterial pressure is measured by a radial catheter, artery catheter, and a venous pressure by the venous cannula. So the mean central pressure is achieved when the two pressures equalize. Next slide. The normal value is around 16 to 24. It is possible in spontaneously breathing patient, non-sedated patient, and also patients with arrhythmia. It needs only one reading, and it has been assessed as a predictor of fluid load responsiveness if you are giving a fluid minimum fluid challenge of 4 ml per kg. Next slide. However, when we are doing an auto flow stop in the arm, so what we are generating is an autoregulatory hypoxia, and this hypoxia could induce a vasodilatation, and that could hamper our readings. This technique also causes a smooth pooling of blood as venous flow stops before the arterial flow. Next slide. So in the analog technique, what we use this equation. So the average baseline MCF values come between 14 and 18. This formula basically is based on a mathematical model. So we don't have to go to the details of the formula. However, in the next slide, what is the use? So if you say what is the clinical use of systemic filling pressure? So they are used to evaluate the effect of fluid. PSMF helps us to differentiate cause of high CVP, that is poor cardiac function versus high venous tone. So if we can differentiate the cause, we can address them accordingly. It also helps us in evaluating the effect of a vasopressor and helps us in weaning the vasopressor. It helps us in determining fluid and vasopressor need for a patient on VA ECMO. It also helps in characterizing hemodynamic physiology during pregnancy. Next slide. So now we will go to the shock index. Next one. So shock index basically is an indicator of severity of hypovolemic shock. It is calculated by dividing the heart rate by the systolic blood pressure. Next slide. So these are the values, 0.5 to 0.7 being normal, and as we go higher, the severity of the shock increases. So a value more than 0.9 correlates with increased mortality. Next slide. Why do we need this? It is very simple to calculate, and it helps us in predicting the mortality, the necessity for a massive blood transfusion in patients, and to decide whether a patient needs ICU admission or not, and to assess the severity of hypovolemia, especially when the systolic blood pressure is still within the normal range. So it can be applied on a wide variety of patients of trauma, postpartum hemorrhage, acute MI, stroke, sepsis. So basically, this is a indicator that should be used in the emergency department to take decisions about further management of this patient. Next one. So there are many variations of shock index which have come up. So age shock index is the shock index multiplied by the age in the years. It is a predictor of outcome in trauma patients. Modified shock index is just the reverse formula, heart rate divided by the MAP, not the systolic blood pressure. This also is a significant predictor in emergency, predictor of mortality. Then we have respiratory adjusted shock index, which is the shock index divided by the respiratory rate per minute divided by time. This is used to identify the occult shock. Then we have reverse shock index less than 1 to identify patients at a high risk for more severe injury. Then we have simple shock index, which is the systolic blood pressure minus the heart rate. So usually we get a value in negative. So if it is more than minus 12, then it corresponds to a SI of 0.9. For the pediatric age group, we have got age-specific cutoff values. So it is given in this table. Next one. Very simple as it may look, there are certain limitations of using the shock index. It may have a weak role to play to detect risk of massive blood transfusion in adult trauma, as has been shown by a meta-analysis that has been published in 2023. It has a low sensitivity and high specificity, so may be useful in identifying patients who have a low risk of mortality. And the concomitant use of certain medications, particularly antihypertensives like beta blockers, calcium channel blockers, could affect the vital signs and they could alter the shock index. Next slide. So to conclude, newer concepts help us in better understanding of the hemodynamics, and bedside implementation would require more guidance than what we already have today. So with time, maybe we will have more guidelines coming up to help us in better using these concepts in the bedside to help better patient management. Thank you so much for a patient listening.
I think it was a fantastic talk, very, very crisp, but to the point description of the concepts from physiology, textbook of physiology, how you extrapolate it into clinical practice, and how simple tests can actually guide you for a rational use of vasopressors, fluids, and even differential diagnosis of a patient who has multiple problems. Excellent, Dr. I mean, that was a beautiful presentation. Yeah, Ghanshyam, your comments?
Nothing, Srinivas. I think fantastic, because some of these concepts are very difficult to understand. And thank you, Dr. Vinita. You have kind of simplified the whole some of the most difficult concepts.
Yes, concepts are easy, but we still have to know how to apply it on the bedside.
So just want to add one thing. I think there has been a lot of debate recently about what should be given first, especially on the background of severe sepsis or vasodilatory shock. Fluids first versus norepinephrine first. Because not every patient in a vasodilatory state responds positively to fluids. So in situations where there is severe vasodilatation, and when you give fluids, probably you may not get an appropriate response in terms of increasing in blood pressures because of the vasodilatory state. So some of these concepts can help us definitely in such situations. For example, if you look at the dynamic arterial elastance, if we can measure the ratio between the pulse pressure variation and the stroke volume variation, and anything which is more than 0.5 indicates a severe vasodilatory state. So that could be one situation where you can start your vasopressors very early. Instead of trying to first give fluids and then waiting for some time, and if it's not responding, then considering initiation of vasopressors. If we can measure the dynamic arterial elastance, and if you have a ratio which is more than 0.5, that will tell us that it's a severe vasodilatory state. And in those situations, your initiation of norepinephrine early is going to be beneficial. Similarly, if you look at the diastolic shock index, when you look at the diastolic blood pressure to the heart rate ratio and more than 2.3, and again, that is a situation where normally when there is tachycardia, you expect the a vasoconstriction. It's a normal physiological response. But if your diastolic shock index is more, then again that indirectly indicates that it's a severe vasodilatory state, and probably an indication that you should start your vasopressors early rather than going with continuously pumping fluids. I think just those couple of points that I wanted to add.
Yes, you have highlighted very important aspects. Just to add there, I may also add one point. It is still in most of the ICUs we go by CVP, because measuring the cardiac output may not be feasible everywhere. So the common fallacy that we have is you give fluid, if the CVP is increasing, it is a good thing. But actually, if the CVP is increasing, we are hampering the venous return. So that is where this concept will help us in better understanding and interpreting the CVP rise. So people would stop the CVP because the venous return would stop if we allow the CVP to rise. So going by CVP for the fluid resuscitation may not be a good thing to do. Yes. And like you said, early use of noradrenaline, because in the vasoplasia and the vasodilatory, because there is so much of blood volume that has gone to a unstressed volume and it is not participating. So the vasoconstriction redistributes it into the stressed volume. So early norepinephrine will help us not only in getting the pressures up, but also in limiting the external fluid that we would be infusing.
Yeah, fantastic. I think bringing that concept into bedside is what it means, and I think you are doing the right thing in equating every single number which you spoke about, how it actually correlates into clinical practice. Excellent. Thank you all. Thank you all for joining us. We apologize for the initial technical delay, but end of the day, we've got a very good talk. I think we are very glad that we made this happen today. Thank you, Dr. Vinita, once again.
Thank you, sir.
I'm sure all the youngsters who are listening to this will actually start looking at physiology in a more respectful way rather than just rely on ultrasounds, echocardiograms, and pulmonary artery catheters and cardiac output monitors. If you can do the simple things first, I think most patients will not graduate into advanced hemodynamic monitoring. So please join us again next week for a similar interesting talk. And if you have any comments or queries or suggestions on this talk, please do post it on the group from which you got the link from. And Dr. Binita, one of the moderators, will try to answer them at the earliest. Thank you all and have a good day. Bye-bye.
Thank you. Thank you, Dr. Binita.
Thank you, sir.